Okay, good morning from Oxford. Thank you for joining this webcast. My name is Stephen Mellon. Just as an agenda of the sorts of things that you're likely to see within the next hour, I'm just going to do some quick introductions of my fellow panelists. That's Serum Torlum and Michael Skipper Anderson. The agenda is that after we've made these introductions, I'll give my presentation, which is roughly 25 to 30 minutes, and then there'll be plenty of time for questions and answers at the end. You can submit the questions at any time during the presentation, and you can do that to me or either of my two panelists. I'll take a short break after I've given my presentation, roughly 2 minutes, and then we'll have plenty of time to answer some of your questions. Just a quick word about anybody. I'd like to draw your attention to this slide before I begin. Anybody are the people that are making this webcast possible. So please have a read of this slide. If you have any specific questions about anybody, please get in touch with either the sales team or Michael or Soren. Okay, I'd like to talk to you about a little bit of work that I've done that's used the anybody musculoskeletal model. The title of my talk is Estimating Edge Loading Risk in Patients with Metal-on-Metal Hip Resurfacing. I'd like to quickly mention my co-authors before I begin. That's George Grammatopoulos, Michael Anderson, Hemant Pandit, Elise Pegg, Richie Gill, and Prof. David Murray. Now, metal-on-metal hip resurfacing is a class of device that is a type of total hip replacement. Total hip replacement is most often carried out to treat advanced osteoarthritis, and the majority of patients will receive a replacement that has a metal on polyethylene bearing. You can see on the right there that this is our conventional metal on polyethylene type total hip replacement. The femoral neck is resected and a metal stem is cemented or press fit into the medullary cavity. And you see on the acetabular side, you have a polyethylene liner inside a metallic cup that is also either cemented or press fit into the acetabulum. In England and Wales, the mean age of patients undergoing total hip replacement is 67 years of age. However, roughly 8,000 operations per year are on people that are younger than 55. For patients that are older than 55, THR provides effective pain relief, it restores their function, and it has really good implant survival. For patients under 55 years, THR also provides great pain relief, functional improvement. However, we know that only approximately 65% of implants will last 17 years, and that's from the Swedish arthroplasty register. In terms of failure, total hip replacements fail most often because of aseptic loosening, which is due to wear. Articulation of the metal head on the polyethylene cup generates wear particles of polyethylene with a diameter of 0.3 to 10 micrometer. The immune response to these particles causes resorption of bone around the prosthesis, which leads to loosening. This is termed osteolysis. Also, 4% of all THR dislocate, and this can be divided into early or late dislocation. Early is usually within 6 months after surgery, and it's mostly due to malpositioned components. Late is most often a product of bearing wear. So, early implant failure is a particular problem in younger patients who are more active and have a longer life expectancy than older patients, and dislocation remains a risk for conventional total hip replacement. So there is a desire for alternative bearing surfaces that have lower wear and allow larger head sizes. Larger heads reduce the risk of dislocation, so that's 32 millimeters diameter and above. And hard bearings reduce wear. That's the choice of hard bearings are either ceramic on ceramic or metal on metal. I'm not going to talk about ceramic on ceramic today, although these are a type of implant that are becoming more and more popular, and more of these are going into patients. Today I'm going to talk about metal on metal. Metal on metal bearings made of a cobalt chrome alloy were first used for total hip replacement in 1938, and they were later reintroduced during the 1950s and 1960s. You can see examples of the various types of design that have been tried out with the early attempts with metal on metal. In 1938, Philip Wiles in the Middlesex Hospital just outside London tried his ball and cup arthroplasty. You can see that on the left. In 1956, McKee's first attempt incorporated an already existing femoral stem, metallic femoral stem, and he added this 3-claw cup. Later on, he then changed to a cemented cup. Peter Ring then, in the 1960s, came up with a different design where the cup was cementless and it was screwed into the pelvis. The survival results for these different types of early metal-on-metal hip replacement are variable, but the implants that did survive exhibited very low wear. The second generation of metal-on-metal articulation devices was introduced in the early 1990s. Metal-on-metal prostheses with a conventional total hip replacement or total hip arthroplasty head diameter exhibited good survival and no wear. So that is between, conventional total hip arthroplasty or hip replacement head diameter is in the range of 28 to 32 millimeters in diameter. And you can see an example of that called the Metasol below. The introduction of the third generation of metal-on-metal bearings was in the late 1990s, and wear similar studies on these devices showed that they had up to 100 times less wear than conventional metal-on polyethylene bearings. The manufacturing techniques of these devices had moved on at this stage to such an extent that we could manufacture much larger femoral components with diameters in the range of 38 to 64 millimeters. And you can see an example of the metal-on-metal total hip replacement below. You can see the large head diameter and on the metallic stem. But this, the fact that we could manufacture these larger head sizes also meant that we could move to a different type of implant, which is called metal-on-metal hip resurfacing. You can see this is a different type of operation where we're not using the metallic stem and you're not resecting the femoral head. Instead, you're reshaping the femoral head and placing cementing a cap on top of there that articulates on the metallic cup. So it's bone preserving and therefore potentially easier to revise. Also, some people think that that these give patients a better range of movement, although that is debatable. So just to give you an idea, just to compare between conventional total hip replacement on the right, so that is the conventional metal on plastic type or metal on polyethylene, with hip resurfacing on the left where the femoral neck is left in place. So for the procedure for implantation of metal on metal hip resurfacing, the recommended orientation of the implant or of the acetabular cup is 40 degrees inclination and 20 degrees anteversion. So these are very surgical terms, so I'll explain what those are. If you can see the image, if you concentrate on the cup in the image, you can see that it's moving. It's moving now, so the change in the steepness of the cup, this is the inclination angle, how open the face of the cup is, so now it's moving back and forward. That is the version or anteversion. Again, at the moment this is inclination and this is anteversion. It's worth bearing that in mind as I go forward through the presentation. The acetabular component in hip resurfacing is less than hemispherical, and coverage varies between manufacturers. Also, there's a diametrical mismatch between the bearing surfaces, so there's a little bit of clearance between the cup and the head, and this clearance varies between manufacturers. All implants and both components are cobalt chrome alloys. So for a lot of patients, metal-on-metal hip resurfacing functions very well, and when they function well, they have wear rates that are less than 5 microns per year. That's volumetric wear. And under optimal lubrication conditions, we get these things called tribochemical reactions between the metallic bearing surfaces and the synovial fluid. This forms organic layers at the bearing surfaces, which prevent metal-on-metal contact and limits wear. However, metal-on-metal hip resurfacings do wear, and we can detect their wear by measuring systemic levels of chromium and cobalt ions in whole blood, serum, or urine, and these have been shown to correlate with the linear and volumetric wear of the femoral component. There is though a running-in phase, and this is roughly 12 months after you've had the operation. After this 12-month running-in phase, systemic chromium and cobalt concentrations are considered surrogate markers of in vivo wear. Just to remind you now as I go through, please bear in mind if anything I say provokes a question, please feel free to type that into this box at any point during the presentation. I or one of the panelists will endeavour to answer your question at the end of this talk. Just a little bit more on wear of metal-on-metal hip resurfacing. In increased wear conditions, there is disturbance of the fluid film lubrication between the components, and there's edge loading. Edge loading occurs when the hip reaction force passes through the edge of the acetabular component, and acetabular component orientation is a factor that influences edge loading risk. If we draw your attention to the diagrams on the right, you can see that under optimal conditions, motion will draw fluid in between the components into this. Because there's clearance between the components, you get what's called an entrainment wedge. But if edge loading is occurring in the bottom diagram, you can see that there's a reduced effective entrainment wedge and therefore reduced lubrication, and you get contact between the two components. This is thought to be implicated in increased wear situations. So there have been reports of soft tissue reactions associated with abnormally high levels of wear to the metal-on-metal bearing, and these present with extensive tissue necrosis, bone loss, and pain. And it was a colleague of mine, Hemant Pandit, who's a surgeon, who was the first to publish on these soft tissue reactions, and he termed them pseudotumours because of they're non-malignant, but they present as almost like a tumour. So they actually present, they can be solid, cystic, or mixed in natures, and because of there's been a number of different papers that have described these things, and they've given them various names, such as cysts, bursae, alval, ARMD, or ALTR. In this talk, I'm going to stick to the term pseudotumour. The regulatory bodies, such as the MOMHRA in the UK and the FDA in the United States of America, have issued guidance related to the management of patients with metal-on-metal hips. This is, sorry if you're of a sensitive disposition, this is a patient that has got a pseudotumour. They're lying on their side here. Their feet are down on the right, and their head is up on the left. So you're looking side on to their hip. You can't actually see their hip, but this white tissue that is in the joint capsule is a pseudotumour, and it shouldn't be there. The incidence for these is greater in females, and this is thought to be to do with differences in bone size and native anatomy. It's also something that's been widely talked about in the media. I'll give two examples here of two articles that were in the New York Times this year about the metal on metal disaster. When you have a pseudotumour, you will need revision to your metal on metal hip, and you're most commonly revised to a conventional metal on polyethylene or a ceramic on ceramic total hip replacement. However, outcome of this revision is generally quite poor, and that's also to mention that revision is a more difficult surgery and it's costlier to the health care provider. So in Oxford we have a metal on metal cohort on which we have done some research. We've investigated 201 asymptomatic resurfaced hips, and we found a 4.4% prevalence of pseudotumour. We measured serum metal ion levels in this patient, so that's serum cobalt and serum chromium, and we found that there was a statistically significant relationship between the levels of serum cobalt and serum chrome and with the incidence of pseudotumour. You see. We also looked at the cup position and the incidence of pseudotumour. So if you look at the graph on the right, each of these red dots represents a case that has a pseudotumour. Each of the blue dots represents somebody who does not have a pseudotumour. Cup anteversion is on the x-axis and cup inclination is on the y-axis. And a colleague of mine, George Grammatopoulos, identified an optimum zone that reduced the risk of pseudotumour by a factor of 4. So you can see that box there now. And I would draw your attention to the fact that outside the box there are some people that don't have a pseudotumour, and there are some people who are inside the box that have presented with pseudotumour. We also looked at serum metal ion levels, and we again with a similar sort of graph. If you on the right you can see with cup anteversion on the x-axis, cup inclination on the y-axis, and somebody who has high metal ion levels is a red dot. Somebody who has low metal ion levels is a blue dot. And again, plotting on that same zone for reduced risk of pseudotumour, you can see that outside the zone you can have low wear, and inside the zone you can have high wear. So the risk of biological reaction is lower for an acetabular orientation of 40 degrees plus or minus 10 degrees inclination and 20 degrees plus or minus 10 degrees of anteversion. However, pseudotumours have been reported in patients with well-positioned components. So our research question was, do individual activity patterns during activities of daily living insulate some patients from the risk of edge loading? So we wanted to recruit patients into specific groups, and we identified 3 groups that we wanted to look at. That was whether they were well-orientated cups or mal-orientated cups. And if they were well-orientated, we recruited patients who had low metal ion levels. If they had mal-orientated cups and they were outside this risk zone, we recruited patients that had low ions and patients who had high ions. This is quite a busy slide, but this is more information about their demographics. I would draw your attention to their the gender in each of the groups in terms of male versus female, and their the size of their component. Those are things that are have a little bit more significance later on. This is also so plotting their cup orientation, again with anteversion on the x-axis, inclination on the y-axis, and plotting on this zone. You can see the well-positioned and low metal ion patients inside the zone, and the mal-positioned outside the zone. This color convention will remain throughout the rest of the talk. So orange for mal-positioned with low metal ion levels, and red for mal-positioned with high metal ion levels. Again, I'll just remind you, if you have any questions about anything that I'm talking about here, please feel free to stick a question into this question box, and we'll get round to answering your question at the end of this talk. So for each of those patients, and there were, we did motion analysis, lower extremity motion analysis, and we looked at gait and sit to stand. So we got their lower extremity kinematics during these functional activities. We then, immediately after motion analysis, we removed the retroreflective markers and replaced them with little metallic markers and sent them for a CT scan. So this gave us the relative positions of the acetabular and femoral components. This then allowed us to get the kinematics of the femur relative to the pelvis, and obviously then the femoral component relative to the cup. This is the kinematics during a typical gait cycle that is repeated. And also, it was important for us to calculate accurately the hip joint centers. For the implanted hip, we chose points at the edge of this of the acetabular component on the CT slices. You can see that these red dots on the right. We then defined a plane through these points, and we fitted. We found the average center point of a number of circles fitted through combinations of the points. The hip joint center was then found by normal projection from the average center relative to the cup diameter and coverage angle. So just to go over that again, so you can see that in this diagram or the schematic on the right, that the red dots are relative to the points that we chose in the CT slices. The orange plane is the plane on the open face of the cup. The yellow circle is the average center of circles fitted through each of these points, through combinations of these points. And then we normally projected out a distance that was relative to the diameter or the radius of the cup and the particular coverage angle for each of the particular type of resurfacing. For the unimplanted side, we had to do something slightly different, and that was that we segmented the unimplanted hip in mimics, and then the hip joint center was found as the center of a sphere that was fitted to the femoral head, and we used geomagic to do that. We then used anybody to try and get the subject-specific hip joint reaction forces. So first of all, a stick figure model was derived based on the markers from the standing reference trial and the hip joint centers from the CT scan and from the segmentation. Next, the stick figure model was used to estimate the kinematics of the patient for the dynamic trials, so gait and sit to stand. And lastly, the Twente lower extremity model was nonlinearly morphed to match the stick figure, and inverse dynamic analysis was performed using the estimated joint kinematics in B and measured ground reaction forces. So we needed a metric to identify edge loading risk, and the metric that we used was contact point to rim distance. This is just basically a distance from the intersection of the hip contact force with the inside of the cup to the edge of the cup. So we found the vector that was in line with the hip contact force, and we used to use a simple inverse cosine calculation to calculate that distance based relative to the radius of the cup. This is something that's been used on a number of occasions by other authors, but it's worth pointing out that each of these papers did this using the static standing forces from the Bergman hip contact forces. So they transformed the static standing hip contact force vector into each of their patients, whereas we've used patient-specific dynamic forces. So now for some results. First of all, we'll look at gait, and you can see on your graph on the left, this is for the stance phase of gait, so from 0 to 60% of the gait cycle. And you can see well-positioned low midline levels are furthest from the edge. it's worth pointing out that the contact point to rim distance is expressed in millimeters on the y-axis, and the error bars in this case are the 95% confidence limits. The subjects in the malpos high group had hip contact forces that were closest to the edge of the acetabular component during the stance phase of gait. We then looked at the lowest 10% per patient of contact point to rim distance. And when we statistically compared using a Mann-Whitney U-test, we found that there was a statistically significant difference between well-positioned and low metal line levels versus mal-positioned and high metal line levels. There was also a statistically significant difference between well-positioned low versus mal-positioned low. And probably most interestingly, there was a statistically significant difference between mal-positioned and low metal line levels and mal-positioned and high metal line levels. We also compared them based on their gender. So when the lowest 10% of contact point to rim distance values for Gait were grouped according to gender, there was no statistically significant difference between the two groups. We then also compared them large versus small, which anything above 50 millimeters in diameter was defined as large. And when the lowest 10% of CPR values for Gait were grouped according to component size, again, there was no statistically significant difference. For sit to stand, the trend was not as clear as for Gait. You can see that there is whereas for Gait you saw three distinct lines and the malpos high were consistently closest to the edge. This wasn't the case for sit to stand. We looked at sit to stand between 20 and 80% of the activity because we define this as being the loading phase of sit to stand. Again, we compared the lowest 10% of values per patient. And again, when we statistically compared them, we found that there was a statistically significant difference between well-positioned and low metal line levels and mal-positioned and high metal line levels. There was no significantly significant difference between well-positioned and low and malpos low, but there was a statistically significant difference between mal-positioned and low and mal-positioned and high metal line levels. Again, we compared them based on their gender, and in this case, when the lowest 10% of contact point to rim values were grouped by gender, there was a statistically significant difference between males and females. And again, when we compared large versus small, and there was also a statistically significant difference between large and small components for sit to stand. So in this study, subjects in the mal-positioned with low metal line levels group had motion patterns that insulated their acetabular component from elevated wear rates caused by edge loading. This could also go some way to explaining why some patients with well-positioned cups demonstrate high serum metal line levels. The results in the study agree with others who found a significant inverse correlation between contact point to rim distance and serum metal line levels, but it's worth pointing out that those were done with a static hip contact force vector. This is a dynamic study. Gender and component size had an effect on edge loading risk for sit to stand, but not Gait. It's difficult to work out what particular role they play, and so therefore further work is required to fully identify their effect. This is the first study that has assessed edge loading risk in resurfaced hips dynamically using patient-specific hip contact forces. And the risk of edge loading is an issue for other hard bearing combinations such as ceramic on ceramic. For ceramic on ceramic, edge loading has been associated with stripe wear and squeaking, so such a methodology may become useful for those types of bearing combination in the future. However, our study did have some limitations. We had a small patient number, and as such we were not able to recruit a well-positioned high ion group. The mal-positioned with high ions group had only 4 subjects, and 3 of whom were female, and the mal-positioned high ions group also had the smallest components. In conclusion, in addition to component position, an individual's motion patterns play an important role in wear mechanisms. Some patients with mal-orientated cups will avoid edge loading with the way they perform daily activities, and the motion patterns that exert this influence over component wear are a result of anatomy and subject-specific kinematics. And these are some people that I'd like to thank. And thank you for your attention. This is the paper reference. And after a short break, we'll be happy to answer some questions. Thank you for your attention. I'll just leave up the paper reference for the time being. Thank you.